Hi everyone, welcome to our webinar on jumping off the hamster wheel. We're so happy to have all of you joining us today. I want to go ahead and introduce today's presenter, Scott Early. Scott is co-founder and president at On Belay, along with currently being a primary care physician. Being that he does practice medicine, he has a special understanding of the importance of value-based care. I'll now turn it over to Scott.
Thanks, Alexis. I'm really happy to be here helping primary care practices get started in value-based care is something I am really passionate about. I have been in primary care my whole career in various leadership positions, and it became quite clear a long time ago that primary care was broken and had become almost impossible. I spent 17 years as a residency program director. Almost all of my former residents were burned out within a few years of leaving residency. So I helped start On Belay to give primary care practices a foundation to finally do what they really wanted to do when they went to medical school, and that was to focus on taking care of patients and to provide the best care possible. So the goals of today's session is to answer the question, well, why should you get started now? And what are some of the things you need to do to start moving away from fee-for-service, and to talk about some sort of actionable next steps. We called ourselves On Belay because, as many of you know, it's a climbing term. And so when you embark on the value-based care journey, it's sort of like climbing a mountain. It's a lot of hard work. There's some danger. And so you need someone who's belaying you, who's holding the other end of the rope. So should you fall, you don't hurt yourself. And then that helps you get to the top of the mountain where you can enjoy the benefits. So this is how I think many patients feel. And this would be funny if it weren't actually true. Please don't waste the doctor's time with questions. And this is how doctors feel. This is actually from a British Medical Journal article over 20 years ago, where they said around the globe, primary care providers were feeling like hamsters on a hamster wheel, running faster and faster and getting nowhere. So what's the root of the problem? I think a lot of it is actually fee for service. What does that encourage us to do? It's just to see more patients more quickly. And that does not align our incentives. It doesn't give us enough time or resources to actually do a good job. We don't have systems in place to give us the information we need. The average primary care provider in the United States has somewhere between 1,500 and 2,500 patients. So on average, they get 60 minutes or less of face time with their provider each year. And if you're a healthy 30-year-old, that might be enough. If you're not a healthy 30-year-old, that's rarely enough. And so that lack of time just fragments care delivery, and it doesn't ultimately result in better care. So in primary care, I think we have sort of felt like we're at the kids' table, and value-based care is going to get us to the adult table, where we're actually able to help make decisions and guide guide our work. So why get started now? Why not wait a little bit longer? I mean, I personally thought value-based care was like really, getting launched 8 or 10 years ago, and it didn't, but now it is. In fact, CMS has a goal of getting all of their beneficiaries into a value-based care arrangement by 2030, and I think they're really serious about that. And there's a lot of learning to be done. You don't just turn on a switch and go from fee-for-service to value-based care. There's learning, and you want to do it right, so you don't want to be rushed. And also, it's just a much more rewarding way to practice medicine. In my practice now, we have resources we could have never dreamed of. We have a nurse care manager, we have a social worker, we have a community health worker. We have information about our patients that we never had access to. So it's a lot more fun, and you can go home at the end of the day feeling like you actually did a good job. So, the primary components of value-based care, you can get, depending on the program, consistent capitation payments instead of fee for service. So you know what your financial resources are. That allows you to make an investment in primary care, and it does take an investment. And that then allows you to move from being reactive to being proactive. And I think that's really the key thing of the difference between fee-for-service and value-based care is you go from being reactive to proactive. And it gives you the resources you need to do a good job. The other team members, it's certainly not just about the primary care provider. You need, care managers and others to really do a good job. So what other benefits? I think most of us went into primary care because, we didn't want to just treat disease. We wanted to actually help keep people healthy. And then you get into that, onto that hamster wheel, and you're running from room to room, and you're mostly just putting out fires. So it gives us resources that you just can't pay for in a fee-for-service system. You're just trying to make payroll every week, and to do the minimum. And ultimately, it's just much better. Patient care and the provider experience, I think, is vastly improved. So, why is it, better for patients? Well, PCPs can have smaller panels, more time with each patient. There is improved access to care. Patients' phone calls can get answers because you actually have the staff to do that. They spend less time in the emergency room. Their providers and other staff are happier, and then that leads to less turnover and better continuity. There are better health outcomes, and there are, just a lot of other resources that their practice has that they would not otherwise have access to. And why is it better for providers and staff? It's a lot of really the same reasons why it's better for patients. It's better care for the patients, and that's what we all want. There's definitely a stronger, more consistent, stable financial foundation. That means you can actually pay yourself more, you can pay your staff more, and that cuts down on turnover. You have smaller panels. That means you can actually spend less time with each patient. You're less focused on visits per hour, which is, I think, just a horrific metric that I hope we can get away from completely. You do have an expanded care team. As I said, in my office, we now have a care management team that makes all the difference in the world. I want my staff to be happier and to not turn over. And again, better health outcomes, additional resources. So let's talk about how you get started, because again, you're not just turning on a switch. It's a process. The graphic on the right is from Jim Collins' book, Good to Great. And he talked about the great companies where they had to build their own foundation. And then that led ultimately to a breakthrough. There's no free lunch. Rashika Fernandopulle, co-founder of Iora Health, he used to say this often, and I would often paraphrase that by saying, you don't get paid more to provide the same old crappy care. So there's a learning curve. It is different work, but ultimately much more meaningful and impactful. And you're able to finally really focus on relationships with patients and improving their relationship to the care team and the healthcare system. And then they are both happier and healthier. So there are some key transitions and differences between fee-for-service and value-based care. So, in fee-for-service, you're mostly, treating disease, you're managing acute problems. And in value-based care, you really want to get upstream and focus on wellness and prevention. You want to keep those patients with congestive heart failure from actually, getting to the point where on Friday afternoon, they call you and say, "Doc, my feet are swollen and I'm short of breath." And you say, "We'll go to the emergency room." So the revenue streams are different in many cases. Again, fee for service, it's how many visits are you doing per hour? Can you squeeze a few more into your day? And in value-based care, you want to move towards capitation, which is giving you a stable, consistent revenue stream each month. And then if you do a good job, you end up receiving shared savings. The population health perspective in fee-for-service, again, just much more reactive. In value-based care, you're trying to know who are your patients, who are the folks who are high risk, rising risk, who are the folks who have been in the emergency room or who have been going to the hospital, so that you can actually prevent that, some of those things from happening. Utilization optimization, again, it's not about visits per hour. It's about, what do we need to do to provide great care to keep people healthy? And in some cases, it's going to be, seeing them in the office. In other cases, it's going to be having a care manager who's calling, patients, weekly or periodically to check in on them. And so it's not just what you do in the exam room. It's in the exam room, it's seeing people in their home, it's talking to them on the phone, it's engaging community resources. It's a different mindset in value-based care. So I guess another piece of advice is don't try to do this alone. You really need the help of others, and you need to band together with other practices. In most cases, you do that through an accountable care organization. And ideally, I think that as value-based care really evolves, it's not just going to be, primary care practices. You're going to be working with hospitals, specialists, other organizations, post-acute care facilities to really provide comprehensive care. Also as a smaller, medium-sized independent practice, in value-based care, there is risk. And so you really can't take that kind of risk until you have, thousands of patients. So being part of an ACO allows you to band together and minimize that risk. It allows you to really, share best practices, to get guidance from experts who have, done this before. It allows you to get a lot more information than you currently have through your EHR. So in our organization, we have a population health platform, and that takes claims data. It also dips into the EHR and helps paint a picture of your entire patient population and identify folks who may have, have slipped through the cracks or fallen off of your radar. By being in a bigger organization, you get access to care management, other resources, and it's again, you're working with peers who are struggling with the same things and learning, and you end up learning together. So some key parts to success, it's about becoming proactive. It's about knowing who your patients are. So we provide what's called an ADT feed, admission discharge transfer. So when one of my patients registers in the emergency department, within minutes, I actually get a notification, and I can call and talk to the emergency room provider, provide them information they need to take good care of the patient. And in my experience, 5 or 10% of the time, that actually leads to the patient not being admitted because the ER doc now has the information they need. You really need to expand access to care. So if you're not already, providing evening or weekend hours, if you're of a size, to do that, that is really helpful. You want to have a way to get your patient seen without them going to the emergency department. One of the, I think, most important things is actually reducing administrative burden. Primary care providers and the team supporting them, they are already completely overloaded. They are on that hamster wheel. So, our approach is to take things off of their plates before we add anything new. You have to give them a little bit of breathing room and a light at the end of the tunnel. You want to, really focus on care coordination and collaboration. Again, we do that with nurse care managers, community health workers, and social workers. You have to have data. You have to be able to, know who those high-risk patients are, and you've got to be able to measure, your progress. And again, with the most EHRs, you just don't really have all the information. It's not easily accessible, so that you have a sense of like, when are you doing things right? What do you need to change? You need to focus on keeping people from going to the emergency room when they don't need to. You need to make connections to your post-acute care organizations. so that, folks are, when they are discharged, that you are able to, pick up the baton and provide care. So a few more keys to success. The graphic on the right is, I think, what most of us already know. In any given year, it's, the most of the expense and utilization in healthcare is by a small percentage of patients. The top 5% in the Medicare population are accounting for a third of all spending, and the top 10% are accounting for approximately 50%. So, we want to provide great care to everyone, but you want to make sure you know who your complicated patients are. I think I've talked about most of this already. Access, care management. I didn't touch on integrated behavioral health yet. I think that if you have a way to do that, it's very, very powerful. And in one of my previous jobs, I was at a community health center with really fabulous behavioral health resources, so that when a patient came in with a behavioral health need, there was actually a member of my team that I could do a warm handoff to. Lots of research showing that integrated behavioral health makes an enormous difference. We haven't talked a lot about risk adjustment and coding, but that is also a key thing. You have to do that well. I think primary care providers sometimes look at this as like at a game and not really adding anything to the care of their patients. I think there's some truth in that. On the other hand, it's the system that CMS uses to decide what your budget is for providing care. And so you have to play by the rules that you're given. We help organizations do that. And then the thing at the bottom, get started. I think that is, you can find all sorts of reasons to delay and to wait and say you're not quite ready. But you're going to learn the most by actually getting started. And so I encourage you to do that. So I'd love to answer your questions. Thank you very much for taking time, and have a great rest of your day.
Thanks, Scott, and thank you everyone for joining us today. There's going to be a short survey for you all as this webinar concludes, followed by an email tomorrow allowing for further feedback and questions. So I hope you all enjoy the rest of your day, and we'll see you next time.